I'm David Williams, and I am the spokesman for Health and Social Care, and I'm the leader of Hertfordshire County Council. As Paul Carter said in his opening address, the imperative in relation to adult social care is something that dominates all of our thinking, and certainly my thinking as a leader of a pretty large authority. The importance of adult social care in county areas cannot be understated. It is the most pressing problem that we face. With a 1.6 billion gap in county social care by 2020, it's essential that we find a long-term sustainable solution. As we look forward, that sustainable solution and that architecture that we need, our expectation is that it will be delivered by the Adult Social Care Green Paper, which, as far as I'm aware, and I don't know about others in this room, David may know better, we are still expecting to be published this year. Now, we've waited some time for this to come. We know that the significance of the funding that the health service secured was and then following on from that, the whole question of producing a plan for the NHS was one of the reasons why this is, the Adult Social Care Green Paper has been delayed. We're told that one of the benefits of Paul, do you want to come and join us? We're told that one of the benefits of this now is that the Green Paper is actually looking at adults with learning disabilities as well. So that's one benefit coming out of this. And we clearly hope that this question of the coordination with the NHS plan, the 10-year plan, is going to provide us with a better and more sustainable outcome. So anyway, to consider this important key issue, we have got three very distinguished members of our panel this morning. It's a great pleasure for me to welcome Paul Burstow. Paul is the chair of the Social Care Institute for Excellence. He potentially, can I announce the Hertfordshire West Essex? No, okay. I have not announced the Hertfordshire and West Essex independent chair of the SDP. Yeah, we won't share that with anyone. Then let me introduce also then David Pearson. David is the Nottinghamshire Deputy Chief Executive and Corporate Director for Adult Social Care, Health and Public Protection. And then I'm also very pleased to introduce Steve Phillips, who's the Senior Partner leading on Whole System and Adult Social Care from Newton Europe. So each of our speakers is going to come up to the microphone, talk for 5-10 minutes or so, and then we'll open it up for questions. So, Paul, welcome.
Thank you very much, and I'm sorry to be sort of rushing in the way I have. Public transport's been a bit of fun this morning. And yes, I hope you can announce fairly soon, but these things always take longer than you think. So what I'm going to do in about the next 8 to 10 minutes is just sort of set out some of the context in which I think we'll be discussing what the potential solutions are to the issues of how we meet the challenges of both an ageing population and the fact that we have far more people of working age living into later life with disabilities of one sort or another. So, so the first thing just to start with is just a statement really. 10 million people today alive in this country can expect to celebrate their 100th birthday and receive that famous telegram. And we know from work by the ONS that we can also expect to see a doubling over the next 50 or so years in the numbers of people expecting to hit that milestone as well. So this is a profound shift that's taking place in the age structure of our country. It's a profound shift that's taking place around the world. Indeed, this chart from the ONS just underscores that point, that we are seeing really in a way global trends in terms of the remaking of the shape of populations, something which often, when we talk about ageing, all too often gets cast in the language of gloom and doom, of consternation. really should be the language of celebration, but it clearly has also to drive innovation when it comes to the way in which we think about meeting the needs of an ageing population, but also the needs of a population that is living longer. And I think particularly the release that you put out this morning about the impact of the costs of dealing with the needs of people with learning disabilities just underscores that point. I thought I'd put this chart up. It comes from some work done for the Royal Volunteer Service, looking at the other side of the coin. Very often, as I say, we talk about these things in negative terms. This is the economic value, the contribution that older people make to our society. £175 billion, £76 billion worth of goods and services that older people purchase in one form or another. And I would also draw attention to the £34 billion worth of informal care, whether that's informal care that older people give to each other or increasingly to their children and their grandchildren. This is a significant contribution which often oils the wheels of our economy, quite apart from the contributions that volunteering and other social action that many older people are involved in contributes. But at the same token, the fact that we are living longer often is not evenly distributed across society. We're seeing in some parts of the nation reversals in life expectancy gains, and we're also seeing that the extent to which people are enjoying healthy life expectancy is, again, far from evenly distributed. And this chart just simply shows the fact that as people age, there tends to be an increase in the numbers of long-term conditions, something that the Office for Budget Responsibility has very much identified as being one of the drivers of increased costs. But it's also the fact that long-term conditions themselves are not evenly distributed across the country, and therefore resources against needs have not been necessarily that well matched. And it's one of the reasons, for example, that the notion that we could sustain funding of social care through the social care precept really doesn't bear much scrutiny, because often it's raising money in areas which have high council tax bases, which don't necessarily have the same levels of need as this chart from an NAO analysis rather demonstrates. You've heard already with the opening remarks from your chair the reference to the funding gaps that exist at the moment. And I think really I'm not going to speak to a particular number. There are a number of numbers that different organisations have given out, but they're all in the same ballpark, all very much the same sort of estimates of the gap. But we know from the budget that there has been some extra money. We ought to welcome that, but we also ought to acknowledge that that falls well short of any of the analysis by expert commentators on what is actually needed. And when one considers that the 410 million that was announced for social care in 1920 is to be shared between children and adult services, it begins to be spread incredibly thinly and rather beggars belief, I think. This chart just makes the point from the work the NAO has done that whilst our adult social care system does receive state support, it's not a state-funded system. It's a state-subsidised system, and over the last decade or so, we've seen pretty much a consistent drop in funding, some uptick in that in the last couple of years. But I think the thing I want to just stress is that very often the discussion about funding overshadows a rather important other discussion, which I think is beginning to be acknowledged increasingly, and that's the issue around workforce. And I think the point I would make here is that we've seen from the most recent figures from Skills for Care that they are forecasting that we will need a workforce by 2030 of around 700,000 extra positions compared to the 1.2 million posts that currently make up the social care workforce. And what they, I think, have done in conjunction with the NAO is really just demonstrated that this is a sector that is beset by rising vacancies and turnover rates, the most recent figures showing that the overall turnover rate in the sector being at 30.6%. And that has a cost. It has a significant implication. If we take the average cost, according to the CIPD, of replacing staff, it comes out at about £780 million a year is being spent, not very visibly, but in managing that churn, in managing that turnover. So just think if we were able to do something about the attractiveness of this this workforce, that we could begin to do something about that. Indeed, some work that was commissioned by the charity Independent Age estimates that the challenge of this workforce is not some sort of in-the-future consideration, looking at the attractiveness of this sector in a number of different likely scenarios. quite excluding implications around Brexit, they've estimated that within the next 2 years, across England alone, we're facing a workforce shortage of over 200,000 workers. So this is a here and now issue, not a future issue. But it's not just a challenge around access to labour that this sector faces. There also is an issue about access to capital. And I put this in the context of research that shows 8 out of 10 UK care homes are over the age of 50. What we know from work done by the Competition and Markets Authority, looking at the care home sector last year across the UK, was that when it comes to the 1 in 4 care homes where 75% of residents are funded or supported by the local authority, in those care homes in particular, the income that's coming in from fees is about 10% below the cost of both running those homes, but then actually providing for the necessary capital to maintain and ultimately replace them. It's why the CQC has documented for the last 2 or 3 years a stagnation in the state-funded part of the sector when it comes to investors putting in the additional capital necessary to replace the current stock. But this is a real issue, which is, again, a slow-motion crisis, but one that needs to be built into the response in the Green Paper. So when does a tipping point tip? The CQC said in their last 2 reports in 2016, they said that we were approaching a tipping point. Well, in their report this year, they acknowledge that there probably isn't an overall tipping point for the sector, that the tipping point is experienced by individuals who face the prospect of unmet need of being directed away from access to formal services because the resources aren't there to provide for them. But at the same time, we have an NHS that has been very successful at making its case for additional funding, and the budget confirmed the extra 20 billion. We wait for the NHS long-term plan to see precisely what that will deliver in terms of the future. Meanwhile, the budget offers pretty much this, a sticking plaster to jog along until hopefully the spending review finally reaches the conclusion that the sector is looking for, which is a long-term funding settlement, and the Green Paper sets out the options and mobilises and delivers those options for securing the extra money. The uncomfortable truth is social care is not free, and the uncomfortable truth is that we have to find ways of raising the extra money to pay for it. And why do we have to do that? Well, because of research that Ipsos Mori has done, we know that only 3 out of 10 people say that they're currently preparing financially to meet care costs. So there is a real issue in terms of preparedness, and indeed understanding of what the social care offer actually is amongst the general population, according to the British Social Attitude Surveys, has consistently demonstrated people think it's more like the NHS, that it's more generous than it actually is. And when this is explained to them, people often say, and I've heard this myself, we paid in all our lives. People are shocked, surprised, and angry when it is explained just how the system is today. So perhaps it's hardly surprising that very often these issues around how we sort out the system are seen as third rail issues, too dangerous for politicians to touch. And indeed, in 2010, when we had the death tax, and in 2017, when we had the dementia tax, we saw the issue being weaponised rather than one that was debated about what the cross-party solution could be. Why does it have to be a cross-party solution? Because this is something that requires people to plan for the long term. It requires markets to plan for the long term. And the only way we get that is by some stability and certainty that one party's solution will be maintained by a future government as well. It's one of the reasons this has been stuck in the mud for as long as it has. Healthcare. I just want to very briefly touch upon why social care matters independently of why it has a good and important contribution to make to healthcare. And part of it is this, that we have a model of healthcare at the moment that I would describe as heroic healthcare, forever diving in, trying to breathe life back into people, to act in crisis, act late in many cases, rather than diving in and finding out why someone was in trouble in the first place, rather than preventing and acting early, something that good adult social care can be all about. And we know that only between 15 and 25% of healthy life expectancy is associated with healthcare. The rest is to do with economics, to do with social factors, to do with environment, to do with psychological factors. I don't know if you've read the book by Atul Gawande looking at his experience and journey through the American healthcare system, but one of the conclusions he reached is that we have a debate in this world around quality of life versus quantity of life, and that we need increasingly to focus on questions of what matters to you rather than what is a matter with you. This chart is far too busy, so I apologise for it being a bit small, but it basically sets out a framework which says we need to focus more on meaning, purpose, and function. If there are any occupational therapists in the room, they would say hallelujah, because that speaks entirely to their practice and their approach. And I'm going to end with a cuddly picture and just make a point from some research which I think speaks to one other area which is absolutely key going forward. And that is from a study by in Ireland of their longitudinal data of older people. And they found this. They found that those within the older population who had negative attitudes to ageing tended within a 2-year period, compared to their contemporaries who had more positive views about ageing, to walk slower, to have poorer cognitive function. In other words, stigma and self-stigma plays its part in the psychology of ageing. And we all have a part to play in changing that, whether we're county council leaders, whether we're politicians, whether we're policymakers. And I hope we can do some of that in this green paper. Thank you very much.
Good morning. When I started as a social worker in 1982, at the age of 23, the average life expectancy of somebody with Down syndrome was 23. Next year, hopefully, I will achieve my 60th birthday, and the average life expectancy of somebody with Down syndrome today is 60. 40% of people over 50 with Down syndrome have dementia, and in the rural parts of Nottinghamshire, we have supported living arrangements for people with Down syndrome over the age of 50 with dementia. Each and every year in Nottinghamshire, there will be a 4.5% increase in the number of people over 85, many of whom will continue to contribute to their communities, but many of whom will live with long-term conditions. It is a fantastic tribute to the 5th richest nation in the world and one of the most advanced economies that we have made that kind of extraordinary progress. But that is the reason why we find today around social care at a junction about how we choose to deal with and to manage the needs of people who have social care needs for support. And building on what Paul has said, I think there are 4 key issues that the Green Paper needs to address. First, funding the existing means-tested system adequately, and Paul has laid out the case for that extremely well. But I think it's also true to just point out that in relation to the 650 million, the spending power of local government goes down by 1.3 billion otherwise next year, so it only meets half the gap. But also, if we think about the difference between the way that health and care have been treated in recent years, health investment went up before the 20.6 billion by 10.3%, whilst gross funding of social care, including self-funders' contribution, went down by 9.9%. And interestingly, the increase of 20.6 billion for the health service announced in the summer is more than the total expenditure on adult social care in England. So quite stark statistics. The second key issue is determining the degree of pooled risk for people who currently fund themselves, somewhere between the bookends of the 23,250 that we currently have and free. And my personal view is that it'll end up somewhere in the middle at some point. But we have had 12 green and white papers and commissions on this subject since 1997, and therefore I think it is fair to say that it is unlikely to go away anytime soon, and so at some point it will have to be addressed, so that people don't feel the unfairness of whether they have cancer or dementia. They don't feel the unfairness of the biggest uninsured risk that any of us will face in our lifetime, But probably more importantly, that we don't have the inefficiency of the interface between two systems that are very differently organised and very differently funded, i.e. the NHS and social care. And then thirdly, many of the areas of reform that Paul touched upon in terms of his analysis. So integration with health, the workforce. We cannot continue to have a social care system that's based on a third of the staff turning over each and every year. That is not a basis for good quality, sustainable care. There are major opportunities in terms of technology and housing, as well as integration, which we must grasp, that will make the system more cost effective and produce better outcomes for our population. And finally, how we as a nation will pay for the 1 to 3 above. And in that context, the County Council Network published a report earlier this year which talked about the various options which have been discussed by the select committees, including social care premiums and the attention to various benefits that are attracted to people of older age. So, a big debate to be had, and we are hoping for clear proposals which the public can debate over the coming months from the Green Paper. I wanted to touch upon, though, what Leo called the light, the opportunities of integrating health and care. I'm not an enthusiast for it just for its own sake, but I have seen it deliver benefits and better outcomes as well as cost effectiveness. And in this context, I speak as one of the only local government leaders in the country still leading an integrated care system stroke STP. And I think the big challenge for us there is to integrate health, which has become incredibly fragmented in its own right over the last 30 years, integrating health and care, but also integrating health care and wider public services, such as housing, community services, planning. All of this plays a huge contribution to the health and well-being of our population. And by having collective analysis of the data, and we're using it in real time to understand the needs of our population and acting quickly, we can definitely make a difference. And other systems in the world have demonstrated that this can be done. And by doing this, we can unlock capacity, work smarter together. So just the context for Nottingham and Nottinghamshire: a vision about high-quality, sustainable, joined-up care, a population of about 1.1 million, spend of circa 3 billion, and what local people want is what they've told us for decades, which is they want that independent life wherever possible, more services close to home, and joined-up services. So very quickly, I want to share 8 examples where I think this is making a profound difference already. So first of all, information sharing. We have 0.5 billion records, which just shows how many records we have across the country, which are joined in a single data warehouse called GPRCC across health and care. This is updated every evening so that the data is real, live and accurate. This leads to better coordination, faster coordination, so a referral from one of the hospitals to social care can take, and the scheduling of the visit can take place in 2 minutes 43 seconds, whereas it probably took several hours or possibly days before, as well as identifying the variation and the proactive care that people at greatest risk need. And this has helped to prevent strokes in one part of the county. It's also helped with the better handling of end-of-life care, where many people, 27% of people, end up in emergency department at times in their lives when it won't do them any good. In fact, it will do them quite a bit of harm. So reducing that by 10%. We've got enhanced care in care homes, which has reduced A&E attendances by 29% and admissions down by 23%. And we've carried out the only piece of evaluation that I know of in this country and internationally into multidisciplinary working in primary care, which has resulted in better health and social care outcomes and reductions in costs, mainly to social care, in fact, of between £2,700 and £4,446. But more importantly, has led to 13% more people supported at home and admissions to hospital down by 12%. So huge differences. A crisis response service in mid-Nottinghamshire, a referral within 2 hours to help de-escalate crises, avoided ambulance transfers, avoided admissions and reduced lengths of stay, a £1.6 million saving to the health service. Housing, health and care, the importance of collaboration with housing, recognised by a partnership scheme which we're now spreading out across Nottingham and Nottinghamshire, with a 400% return on investment by giving people the right information at the right time, with a record of somebody having a referral for a key safe so that they can get home quickly and the carers can get into their house, of 40 minutes between referral and the key safe being fitted. And integrated personal commissioning. 85 peak personal health budgets we had in Nottinghamshire for 6 years endeavour. Absolutely unacceptable. But since we've given this a boost, we've now got 2,000, 500 of which are joint across health and care. And Helen talks about her son Carl, who's a young man in transitions from childhood to adulthood, who has multiple needs and multiple budgets and agencies working with him. And she says the difference was immense. We went from being done to being done with. We worked together so that Carl needs are met in a personal way, rather than one size fits all. So what are the implications for us for this? My personal view is that we need not only to be able to demonstrate to government, to the communities, to politicians of all sides, the importance of social care, but also, and the difficulties it's facing because of the current funding issue, but we need an investable proposition. And in that regard, Britain Think surveyed local government leaders and concluded there was broad agreement on place-based integration as better and more cost-effective. Well, that's very good because that's what the international evidence tells us. Concerns about the engagement, but my argument is that we have to make this work. There doesn't seem to me to be a better alternative. So, local government as an investable proposition then, that thing about bringing together wider public, private and civic endeavour, brings the strength of local democracy and different relationships between citizen and the state. Population health and wellbeing management is absolutely something we are concerned with. And a strong health service and a strong social care public health service working together, but with different cultures. We are still stronger together. We bring different things. Notts was the first STP to have housing environment in its plan as a key plank, and a whole system, person-centred approach for cohorts of people who need proactive, coordinated care. So, what are some of the difficulties? Well, the cultural difference between the national NHS and local government are significant. Can we work together when we come from different groupings, different tribes? One doctor suggested that social care was the orangutan, near extinction, but with a long reach. So we've got to make this work, and what this demonstrates is the different cultures, the different interests, the different national and local accountabilities, and what we've got to overcome. So, in summary then, we are some way from having an adult social care system fit for the future, the market, the workforce, and consistency. And Steve will go on to talk about consistency and variation, which we need to address too, collectively. If we are to make progress, central government will need encouragement for local government collectively. Our power has been dissipated in central government because we haven't spoken with one voice enough on this issue. Change is required in all the 4 policy areas. It won't work just to pick and choose. They need progress together. And local government needs to be at the forefront of a strong narrative about the investable proposition. The best systems in the world have strong health and local government, political and executive leadership. There is a huge opportunity. Thank you.
Thank you, David. So my role sees me working right across the health and social care system, but my area of practice where I've been working for more than the last 10 years has been adult social care. So I just wanted to build on what my colleagues have been discussing, and it was interesting to see so much of that this morning as well. But from the perspective we wanted to bring across and add to this debate was within the context of the essential financial reform of which there is overwhelming evidence for, we feel to really ensure a sustainable future for social care, we believe it's critical to recognise the current operational reality that exists at the front lines across all the services we deliver nationally at the moment. So from our evidence-led work that we do nationally and with a number of your organisations as well, it is evident that across the health and social care system, close to 50% of people that are currently receiving support are not able to access the best services to enable their independence. And from the points that Paul and David have already just stressed, this is the outcomes that people want to receive. They want to be at home. They want to be able to operate effectively in their communities and to be independent. So to translate that rather large percentage into some specifics, what that would mean was nursing and residential home placements could be reduced by almost a half. People going home, straight home up from post-assessment, particularly after a period in an acute hospital, could increase by almost a third. And people going home with reablement-based services could increase almost threefold. So as well as a fundamental step change in outcomes for these individuals, we believe this would contribute to a more sustainable system in the future and help to bridge the gap, both in terms of financial sustainability, but also the pressure on providers and the pressure on workforce that has been stressed already. So the key question of how to make this situation better. To make an improvement, we feel it is necessary to understand the current operational reality, and particularly what is driving the biggest factor of variation in the decision-making throughout our health and social care pathways. So we gather information at the front line and working with organisations across health and social care in a number of ways, but one of them is to actually work with existing practitioners looking at the cases currently existing within systems and try and understand whether things could be better for those individuals. So one way of doing this is we take a real-life case and we share that out amongst a number of practitioners, and we ask them independently to develop what they feel would be the best care package for that individual, delivering the most independent outcomes. And we have done this thousands of times across the UK, and every single time we do it, the practitioners come up with a different nature of support, offering a different range of services and at a very different cost. 100% of the time that is also different from the package that individual is in receipt of. But I think probably most strikingly and where the potential is that actually when those practitioners are able to work together in a collaborative environment, 100% of the time they come up with something that is very realistic, but more imaginative, more innovative, and able to deliver better care, more independent care for that individual, but also at a reduced cost. So that tells us that the level of variation we see is about the individual and not about the level of need that the service user is presenting. But it's vital to stress that people aren't actively wanting to make non-ideal decisions. So if we're able to work with practitioners within your current systems, looking at demand within your current systems, and to highlight such a step change in potential difference in positive outcomes, the big question is, why is that currently in existence and what can we do about it? So unfortunately, there isn't one solution. Rather, it's important to understand the deep complexity that exists operating within health and social care systems at the moment, which needs to be worked through to enable this scale of change. So it is essential that the introduction of any new model of care, and a number of your organisations will be seeking to introduce, whether it's strengths-based model of care, asset-based models of care, the three-conversation model, and lots of other fantastic ideas around delivering different models across health and social care, that 90% of the effort is on the evidence-led implementation to tackle and work through all of these complex issues. Importantly, make sure that the benefit and the step change is measured effectively and that those new models are iterated at the front line, embracing the knowledge of the frontline practitioners to really deliver something quite strikingly different for the service users it's important that we care for. So therefore, in conclusion, while throughout this morning, and I'm sure in the questions that will follow, the financial reform is fundamentally essential. I think the evidence base for that has been made and continues to get richer. But it's vital that any new money that is secured and any reform that comes through the system is not simply focused on addressing some of the fires and some of the holes, whether it be provider stability, workforce, but actually is used as an enabler to realise a future system which can deliver a step change in outcomes and, importantly, independent outcomes for the people that need it the most. Thank you very much.
Thank you for those contributions. Before I open it up to the audience, Paul, can you just give us your perspective on the time frame now? So, NHS plan, green paper, general election in 2022, potentially. When could we see some of the things, and I'm hoping that we are going to see some good things in the green paper, some things that we support. When can we expect to see some of those being adopted?
Right. Wow. Let's start with a nice, easy question. Thank you. So I think there's two parts to that. I mean, there's the Minister of State, Caroline Dinenage, at the NCAS conference last week, made it pretty clear that the Green Paper will be a mixture of both very green proposals and some very sort of specific things that will just be got on with. I think the stuff that will be at the got on end of the spectrum will be more about how to drive innovation. It will be about some of the issues around how you address variations in performance in systems. So it'll be at that sort of end of the spectrum where we're likely to get some, if you like, some investments and some policy pronouncements and some direction. I think on the very green end of the spectrum, we'll have some canvassing of a variety of options around how to address how do we get more money into the system. One of the areas that is now being speculated about, and if it were to be the case, certainly I would be very supportive of it, is that we have two select committees who published a joint report earlier this year looking at options for long-term funding of social care. They came up with a broadly agreed proposition across party on those two select committees. It was a proposition of a form of social insurance, social care premium, a mandatory payment from the age of 40 that would begin to generate the sorts of sums of money to pay for the system. If that were to be proposed, it would require legislation. It would require legislation to be set out in the Queen's speech. So we are going to be very close, to answer your question, to when this Parliament, at its most extended, would run out of time. But it's not yet beyond the bound of possibility, if there were cross-party consensus, as those two select committees achieved, to still legislate in this Parliament to put in place some sort of system. So as someone who always travels with a great deal of hope, that would be where I would hope we will land, but it will require quite a lot of determination at a time when the bandwidth to do much other than the stuff that's in our news all the time at the moment is denying government the time to think about these things.
Okay. David, do you want to come in on that time frame?
Just briefly, if I may. I mean, I think we still think it may come out before Christmas, but we don't absolutely know. There's a meeting this morning taking place, so we'll see. The second issue is that when Paul and I are on the panel, which is advising the government, and when I took that on, I didn't expect all the financial solutions to be laid out when the Green Paper came out. I did always expect it to be fed into the Comprehensive Spending Review. So that still remains absolutely hugely important for organisations like this and everybody else now in the future. I suppose the other 2 points to make are that 49% of the Great British public still think social care is free at the point of delivery. So we have a major job to do with our communities as politicians and senior leaders to make sure that we explain that. I think, secondly, it was quite interesting, the Mori poll in the summer said that 77% of the population would be prepared to pay extra taxes or pay more for the NHS. 83% said that for social care. I'm not saying that's the solution. What I'm saying is there is a groundswell of opinion that can be built upon. And my hope is that the Green Paper absolutely articulates what the options are so that there is a meaningful discussion about these things.
Okay, thanks for that. So, can we put the lights up and get the microphones? Have we got the box, or has the box died? No, we're on microphones. So, we've got a question from Hampshire.
Keith Manns, Deputy Leader of Hampshire County Council. Recently, the new Secretary of State for Health indicated that he wanted to shift the emphasis to some degree from spending on acute hospitals to spending on community facilities. Does the panel agree that any paper that's published on social services has to have as its prerequisite that change taking place? Otherwise, we will simply continue as we are, not working closely enough with the NHS or them with us to provide the sorts of services that are required by people who really don't quite often know whether their need is a medical one or a social services one.
Okay, Paul, do you want to start us off on that?
Yes, would be the very straightforward answer to that question. I think that is, in a sense, implicit and, in some cases, explicit in the ambitions of sustainability and transformation partnerships and the ambitions around integrated care systems. I think there is an issue about the transmission mechanism between that intention and its execution, because the focus in practice is still on fighting all the fires, dealing with the pressure at the front door of the hospital, and the issue is how you make the system begin to focus more on those longer-term transformations that you need to have, which is where I think the social care piece and indeed the public health piece that local government brings to the conversation are absolutely key, because those are the things in terms of the asset-based or strength-based approaches that social care is increasingly adopting are incredibly relevant to managing demand differently, to actually making people more resilient, to supporting community-led approaches. So absolutely agree that as the leader of place, local government is best placed to make those cases.
David?
Yes, I agree too. I think it does need to be done as a collective effort. And the reason why I say that is because if we put in the community services, but we don't work as a whole system in the way that some of Stephen's work has demonstrated, then the hospital will always continue to draw people to it, partly because the public trust hospitals, but partly because that's how the system has been designed over the last 30 years through payment by results and the way in which hospitals get paid. So getting the whole system to understand what needs to happen in terms of utilising that community provision. And that's exactly what's happened in mid-Nottinghamshire. It was a failing hospital with a huge PFI deficit. It was nil point on CQC ratings and very poor on overall quality and response. And by working in a collective way to do just what you're suggesting, there was a 4.1% reduction in A&E attendances and a 6.7% reduction in emergency admissions last year. And that's because of those community facilities that were put in place, the call for care, the multidisciplinary working. Integrated working around cohorts of people who have significant need is the way to go forward.
Steve, do you want to comment?
Yeah, I definitely agree as well. And I think what we see is absolutely that's essential, but it's the complexity and how to realise that in a way that is properly sustainable, both in terms of the funding, but also the operational reality of that. We're doing some projects with in a number of your areas, but I think most significantly at the moment, right across the Birmingham health and social care system, looking from the front door of the hospitals, through the hospitals, the discharge from hospital out into community health and social care. And absolutely, the transfer of funding and the understanding where a more sustainable future delivered in the community is vital. But I think there, and with most of our programs at the moment, there is a stream which is how do you get sustain the grip on the current operational reality to make sure that the funding is enough to get by, while also in parallel trying to put the more transformed, sustainable options in place for the medium to longer term. And I think anyone that doesn't do both is running into quite a considerable amount of risk. So I think it's vital, but there's a lot of complexity to it, properly realising that.
Okay, next question. Yes, sir.
Cornelius Olivier, member of Cornwall Council representing Penzance. The first two speakers mentioned turnover in social care staff, care workers being a major problem, a major contributor to poor quality of care. To what extent does improving the conditions of employment of care workers, creating more of a career structure, and introducing the foundation living wage for care workers, as is being done in Cornwall at the moment, part of the solution?
David, do you want to start us off?
Yes. So I think I've come to the conclusion that until we have a more regulated social care workforce, as they do in other countries, we will not make the kind of progress that we need, because there's always a flip into social care and then a flip out into the retail sector and other services, because there isn't. So for career structure, I think we also need some accreditation of training and development and registration. Skills for Care proposed this in some of their early work earlier this year. And indeed, it's the Australian government have just produced their workforce strategy for social care, which has elements of just that. Clearly, money and funding. So one of the problems is that if you want to pay a care assistant, typical care assistant, the same as you pay a healthcare assistant, we'd have to increase their wages by 29%. So we need to join up the workforce planning between health and care nationally and locally. And I think inevitably that will, as the economy moves forward, that leads to needing greater levels of remuneration for the staffing in order to retain them and to do the things that we're talking about. So all of those three things I think are needed.
Just very briefly, I agree with all of that. And take some heart that David Behan's now taken on the chair role of Health Education England. I think his background will be very helpful in terms of driving some of the debate about a genuinely integrated workforce planning, one that doesn't just result in the NHS sucking up all of the workforce from the social care side. It needs to be a different dynamic to that. I think the other thing is the language we use. Very often the narrative is one that portrays this sector as not just low paid, but also low skilled. And yet we are actually talking about a workforce that we are trusting and entrusting to do some of the most complex and challenging work in society in terms of the way they relate to the people they are caring and supporting. So the language we use can itself be alienating and off-putting. Therefore, I think it's quite important in terms of the way in which we talk about this sector and the workforce within it. We use language that is very much one that frames it in terms of the very positive experience that people can get out of working in these roles and just how skilled they actually are, even if they don't have the paper qualifications to demonstrate it. In reality, they are doing very important work.
Yeah, again, agree. I think we see real issues with availability. So even when people secure funding, the ability to go out and access the provision is really pressured, particularly across county areas. I think the worst examples we see when health and social care isn't working effectively together is that there's almost competition for that local workforce in the way that Paul just highlighted. But also where we see that people work, where it's working most effectively, investment in that frontline workforce can actually save considerable amounts of money in terms of enabling people to have the time and the space and the right skill mix of people to deliver the best outcomes for people, which is ultimately more independent care. So I think there's a good business case for where investing in the workforce is probably one of the biggest priorities, if not the biggest priority currently operating within the system.
I must admit, I had my own experience the other night of an award ceremony run by a not-for-profit residential care provider locally. and the recognition that was shared out by the management of this company was astonishing, and the response of the staff to that was astonishing as well. It was a really fun evening, and you know, some people clearly do invest in recognition and career development, and as a consequence have significant benefits in terms of turnover, etc. Next question. Yes, Teresa Heritage.
Hello, Teresa Heritage, Deputy Leader of Hertfordshire, and I lead on children's services, more specifically. David, could I congratulate you on the model that you have in Leicestershire, especially around the data sharing? That's absolutely fantastic. Can I just check in with you that it includes children's services as well? And then if it does, because you're nodding your head, have you got any hints and tips how we can get that type of sharing with our CCGs, etc.? Because I noticed you've got quite a few, so really good.
Yes, so the answer is it covers cradle to grave and right across the system, although the application of it has to be rolled out slightly differentially to conform to the requirements of the data protection. So you've got to do things proportionately. So we roll it out, and the particular visibility of data depends on what your service is. So, for example, you wouldn't enable children's services colleagues to access adult care data unless they had a need. So you've got to work through that stuff. But the key to it is, we had a GP, an inspirational GP, who designed this system in his bedroom, which makes me worry about his health and well-being and getting run over by a bus, as I tell him frequently. But secondly, more importantly, we persuaded 100% of GPs to sign up to the data sharing protocols in Nottinghamshire. And that's meant all of the data comes into the system. That's absolutely crucial. So we've got a model, we've got a data warehouse. It's tricky, it's being designed. We haven't spent huge amounts of money with some company somewhere. It's being designed locally. But in order to do that, you need the 100% of GPs and people working on it to make it produce the data appropriately. Happy to share that outside.
Okay. So let's move from Hertfordshire to Essex. Kevin.
David, thank you. Kevin Bentley, Deputy Leader of Essex County Council, and a brilliant presentation and a lot learned this morning. My question is around the funding. So for 30 years or more now, we've been telling people how to live a healthier life, a better life, live longer through stop smoking, eating better, exercise, all that sort of thing, which has been superb. The bit of the conversation that hasn't been had is, and who pays for that healthy retirement and longer life? So we've done it around pensions, but not around healthcare in the future. And if people are going to spend, hopefully, because all this is good, as much time in retirement as they do in working, we've got to have a conversation about who pays for that. And it can't always be the state. That's why we're in this financial issue at the moment. So my question is, who do you think should have that conversation, and what should they be saying to the next generation?
Paul, can I ask you to lead on that?
Two or three things. One is the government's industrial strategy that was published last year identifies a number of challenges, one of which is how we have a population that is aging more healthily than it currently is, and the goal, I think, by 2030, 2035, that we have an extra 5 years of healthy life expectancy in our later lives. That's absolutely the right goal. The industrial strategy also says that the best way to invest resources in those sorts of achievements is by pooling risk across society. I think that conclusion that is part of the industrial strategy white paper would be very helpfully articulated in the green paper for adult social care as well, and would help immensely in terms of answering some of the questions about how we share the risk across society of drawing the short straw and facing catastrophic costs of requiring long-term care. And I think the answer is that you can only do these things by having arrangements that are ones that can last the test of time. We all expect, if we're in government, to be in government forever to some extent. When we're legislating, we hope we will be, but we're not. And as a consequence of that, we have to have something that, especially when it comes to these sorts of very long-term decision-making matters, where people can be confident that the thing will survive, especially if they're paying money into it, which is where the Joint Select Committee report on the funding of social care, which I referenced earlier on, I think does offer a potential route It's already secured cross-party support between those two groups who've looked at the issue in some detail, and I think it does provide a way of having a meaningful discussion with the public about the fact that if we want to have a healthy ageing society and a good quality of life in later life, we have to raise more money to pay for it.
Anything to add, David?
Yes. So I think first of all, as a director of adult social care, we spent some time about 10 years ago trying to persuade people to invest in products that would support their long-term future care needs, and singularly didn't get very far with it. And I think the evidence across the world is it doesn't really work. Everybody thinks they're going to need a pension because they're going to grow old. Very few people think they're going to need any care needs. So in Singapore, where they've introduced an auto-enrolment scheme for care needs, unlike pensions here, where 93% of people continue with the auto-enrolment, it's dropped down to 70 in Singapore, and now they've reduced the age to 30 and they're making it compulsory. So there is something about that we have to sort of stare at and consider. Secondly, and my final point on this, is that there is Tim Evans from the World Bank recently, in an article in The Economist recently, described the system where we let people pursue their own devices as a cannonball of inefficiency. So if you think that 50% of the people in Nottinghamshire are not the responsibility of the Adult Social Care Department, other than to do an assessment, but 49% of people don't think it's free at the point of delivery. The cannonball of inefficiency is people making the wrong decisions and taking time over those because they're shocked at the fact that they've got a big bill to pay. So I think there is an issue for the health and care system in this country about what makes the best, most efficient system for the public purse, given that social care is only 1% of GDP. It is relatively inexpensive and highly effective when it works properly.
Okay, thank you. So, one more question.
Thank you. Amanda Jupp, lead member for Adults and Health. Would the panel agree that the acute hospitals could work in collaboration with local sixth form colleges, FE colleges and universities to produce training facilities for the workforce so that it would benefit all of us?
So question, training, skills, education. David, do you want to start?
Yes, I absolutely agree with you. I think, though, we need some levers. So I think that my hope is that the NHS plan and the Greek paper joining together provide some levers for this to ensure that we have a national plan that's linked the adult social care and health staff, but also there's an expectation on local systems, including integrated care systems, to provide those workforce plans, but some levers in terms of the funding envelope being flexible across health and care in order to fund those things, because they need those kinds of levers. It's not a huge thing to ask, really, given it's 1.5 million staff, more than the NHS. And as Paul rightly points out, dealing with many of the most significant need in our country. So I think your idea is absolutely a good one.
Yeah, we ran a campaign, the so-called Good Care Month, and we were able to get some stories of people who'd come into the care sector and progressed in the care sector. And that was one way that we chose to focus on the opportunities that exist in the sector. And equally, it got us quite a bit of positive publicity, local regional news, etc. So it's something that we're going to be continuing to do year on year. Time is going on. We are now going to break for a cup of coffee. No, we've got the Secretary of State here, so we haven't got time for a cup of coffee. So at this point, can I just ask you to thank our panel this morning? Thank you.